Imagine going to doctor after doctor, striving to find an answer to your debilitating pain. Month by month, visit by visit, you are told it's just stress, anxiety, or that things like painful periods are simply part of being a woman. Years pass before anyone finally gives your symptoms a name: endometriosis. This is not an isolated experience, but rather a pattern that most women endure. Despite making up roughly half of the world's population, women's bodies have historically been overlooked in medical research. While medicine has advanced dramatically over the past century, much of what we know about disease, treatment, and even pain has been built using male bodies as the default. Even popular TV shows such as Grey's Anatomy have taken notice, like when Meredith Grey shows her frustration after learning an Alzheimer's study only used on male mice. Quote, "Did it not occur to anyone that female mice might respond differently?" she asks, as she then calls it pathetic and a, quote, asinine excuse for sexism, that they only use male mice because female mice's hormones create additional considerations. While this scene may be fictional, the problem itself is very real. The result isn't just a gap in knowledge, it's a gap in care. So why are women's bodies so understudied in medicine? Let's examine some history for our answer. For decades, researchers routinely excluded women, especially those of childbearing age, from clinical drug trials. Following the thalidomide tragedy of the 1960s, in which a drug trial caused major birth defects, concerns about harming a fetus led many researchers to avoid studying women altogether. While intended as a protective measure, the consequence was that medications and treatments were often tested on males alone and then prescribed to women under the assumption that their bodies would respond the same way. Although the U.S. policy changed in the 1990s to require the inclusion of women in federally funded clinical research, the effects of decades of exclusion still remain. Even today, researchers continue to rely heavily on male animals and male cells in preclinical research, limiting what scientists know about how diseases and treatments affect female biology differently. In 2016, the National Institutes of Health, or the NIH, introduced a policy requiring researchers to consider sex as a biological variable because these differences do matter. Just a reminder, 2016 was only 10 years ago. While this was a step in the right direction, policy changes cannot erase generations of missing data overnight. The consequences become especially clear when we look at diseases that primarily affect women. Take lupus, for example. According to the Cleveland Clinic, lupus is an autoimmune disease that makes your immune system damage organs and tissue throughout your body. Approximately 9 out of every 10 people diagnosed with lupus are women. Yet, lupus remains a disease with no cure and one that is notoriously difficult to diagnose. Many patients, myself included, spend years searching for answers because lupus symptoms can mimic dozens of other conditions, ranging from fatigue and joint pain to kidney disease and neurological complications. This diagnosis challenge isn't simply because lupus is complex. It's also because autoimmune diseases, many of which, again, primarily affect women, have historically received less attention than diseases affecting broader populations. To this day, researchers still don't fully understand why women develop lupus so much more frequently than men. Hormones, genetics, and immune system differences are all possible explanations, but we still lack significant answers. For millions of women living with lupus, those unanswered questions translate into delayed diagnoses, limited treatment options, and years of uncertainty. The same pattern appears with endometriosis, a condition where tissue that is similar to the lining of your uterus grows on other parts of your body. This often causes severe pelvic pain, heavy bleeding, digestive problems, and infertility, and it affects about 1 in 10 women of reproductive age. Yet, the average diagnosis takes years. During that time, patients will frequently told that their pain is normal, exaggerated, or even psychological. Many women cycle through multiple doctors before finally receiving answers. Part of the problem is that diagnosing endometriosis has traditionally required laparoscopic surgery, but another part is far more systemic. Researchers simply have not invested in understanding the disease at the same level as many other chronic illnesses. So why is it that pain that would ordinarily be investigated immediately in other contexts becomes normalized when associated with menstruation? This creates a cycle. Limited research leads to fewer diagnostic tools. Fewer diagnostic tools contribute to delayed diagnoses. Delayed diagnoses reinforce the misconception that these conditions are simply difficult to understand, when in reality, they have often been difficult to study because they were never prioritized. This raises an important question. If medicine is supposed to be evidence-based, what happens when the evidence itself is incomplete? The issue extends far beyond women's reproductive health and autoimmune diseases. Women often experience heart attacks differently than men. Women experience adverse drug reactions at higher rates, in part because medications developed using male-centered research may not account for biological differences in metabolism, hormones, or immune function. Now, none of this is to say that medicine has ignored women completely. In fact, progress has been made over the last 3 decades, significantly. Women now participate in far more clinical research than they once did, and institutions like the NIH increasingly require researchers to analyze data by sex. These are meaningful improvements, but inclusion alone isn't enough. Researchers also need sustained funding for diseases that disproportionately affect women, better education for healthcare providers about sex-based differences in disease presentation, and continued investment in understanding female biology rather than treating it as a variation of the male body. Because women's bodies are not simply smaller versions of men's. They have unique physiology, hormonal cycles, immune responses, and disease patterns that deserve to be understood on their own terms. Ultimately, this conversation isn't just about fairness, it's about better science. When half the population is understudied, everyone loses. Medical discoveries become less accurate, treatments become less effective, and patients continue to suffer from conditions that could have been understood years earlier. Women's health has never been a niche issue. It is simply human health care, and until medical research reflects that reality, the gap between what medicine knows and what women experience will continue to grow.